presentation. If you could please tell me whether you all hear me or share it in the chat, I would appreciate it if you can all hear me.
Yeah, we can hear you and we can see the screen.
All right, that's perfect. So today I'll be discussing neurological examination, and so neurological examination is very important. Its purpose is to determine the neurological deficits, whether sensory, motor, behavioral, or coordinative. It also helps us know the site of the problem and the cause of the problem. So in neurological examination, we focus on evaluation of mental status, the function of cranial nerves, motor, sensory, coordination and balance functions, as well as reflexes. So the first thing we should do is to take the patient's history. History is very important, just like in any physical examination. It is important to ask the patient about their chief complaints, any symptoms they have, like, so the presenting complaint means the symptoms, whether, for example, headaches, weakness, numbness, decrease in sensation, difficulties in movement, and when the symptoms started, how long they've been going on for, whether the onset was acute, it means sudden, or was it gradual onset, and if there's any history of trauma before. And you should also ask if the symptoms were localized to some part of the body or if they have affected more than one part of the body, and if there is anything that worsens the symptoms or anything that makes the symptoms better. And if there's any specific trigger like sleeping, exercising, exposure to external stimuli like cold or smell, associated symptoms like altered consciousness, visual disturbances, nausea, vomiting. And you have to also ask them if the symptoms affect their daily living, and if they, if they're able to live with it, and ask them about their performance in school, at work. So this is all about the presenting complaints. A past medical history is important because we should ask them mainly if they've experienced any kind of neurological deficit before or any kind of neurological problems, if they have had any neurological disorders before, if they have any other medical conditions or medical history, if they've had any infections in the past, a history of seizure, injuries in childhood, trauma in childhood or in adult life. Ask them about infections, particularly meningitis, encephalitis, and the history of head or spinal cord injury. Regarding the social history, the most important thing is to ask about smoking and drinking, particularly alcohol, of course, and if they've used any like drugs like and not like, I don't mean over-the-counter drugs, but illicit drugs, mainly like amphetamines, cocaine, and drugs which like hallucinogenic drugs. Ask them about their sexual history as well, because certain disorders like syphilis and HIV can also affect the functioning of the CNS. And for family history, it is important to ask them about any kind of neurological disorders that run in families. So we notice, or what is really important for us is Huntington's disease, because it's inherited in an autosomal dominant fashion and it's very common, as well as Duchenne's muscular dystrophy and Becker's muscular dystrophy. Other neuropathies like epilepsies and migraines are also important, particularly migraines, because it's inherited in the families and it's very common among females of middle age. And then for the mental status, so we evaluate the patient's alertness, if they are alert, cooperative, if they are oriented in time, place, their cognitive function, if they are aware of their surroundings, they're able to answer our questions, the memory, and their speech, if it is fluent speech or if there is some kind of speech disorder. The levels of consciousness, we have 3 main levels of consciousness: alert, and then if they are not alert and oriented, then it can either be stupor or coma. So we evaluate the level of consciousness based on the Glasgow Coma scale, and we have 3 components: eye-opening, verbal response, and motor response, and each component is given a score. The total score can be from 3 to 15. The maximum is 15 and the minimum is 3. A patient would need to be admitted to the hospital if the Glasgow Coma scale is below or equal to 8, because then the patient has a likelihood that their brain is injured, and we would need to further evaluate them. So for cognitive function testing, which we've mentioned before, it is important because we evaluate the mental function and we see if the patient has some kind of problem with their cognitive skills. It means that we should ask them about, for example, things like vocabulary, solving simple mathematical problems, asking them, for example, to name the shapes that they see, like circle, rectangles, the clock. So this is basically the cognitive function. There's something known as a mini cognitive function test, which we can also perform. Regarding the visual disturbances, we evaluated based on history as well as physical examination. So if there's any visual disturbance, we just ask them if when did it occur and how did it progress, and was it transient or was it means like persistent if it lasted for a longer time. And if they see any visual, how to say it, halos, hallucinations, like visual aura, for example, which is associated with migraines, like when they see flashes or a different like shapes, rainbows, halos. Vertigo. Vertigo is a disturbance of balance, and it's a sensation of spinning, and it can be a problem either in the vestibular apparatus or in the vestibular nerve. And it is important to distinguish vertigo from lightheadedness and faintness, because lightheadedness and faintness, or transient loss of consciousness, or we also call it syncope, results from an impairment of brain oxygenation and perfusion, and not from a problem within the CNS. The Dix-Hallpike maneuver is just to tell if a patient has positional vertigo or not. It's not really done anymore, so not so important. Examination of speech is mainly done to look if the patient has some speech disturbances, which is associated with a lot of medical conditions. So we ask them for naming objects, for example, to carry out some commands. It means we ask them to do something like raise their hand, walk through the room, because this helps us evaluate if they're able to comprehend or understand the speech. We ask them to read aloud, to repeat a sentence, and we look at their handwriting as well, because it might suggest some global problem and not just a speech disorder. Aphasia is a problem with speech, and it can be either verbal aphasia or it can be motor aphasia, depending on which brain center is damaged. It means that it can be, for example, word comprehension. It means understanding the speech, repetition, naming objects, reading comprehension, writing. These are the things which are important to test for when we are evaluating speech disorders. So we ask them if they're able to understand comments that we give them, to repeat words, to name objects around them, to read certain phrases, and to write a sentence, and we evaluate. Localization of a problem can be within the central or the peripheral nervous system. It means brain, spinal cord, or peripheral nerves. And it's difficult when evaluating if the localization is central or peripheral when a patient has radicular pain, dysesthesias, paresthesias, tremors, and incoordination. And that's because problems within the CNS and the PNS both can cause symptoms which are, let's say, coinciding, or that occur like if a patient has a CNS or a PNS problem, then they could have similar symptoms. So it can make localization difficult, which makes further evaluation with other techniques like imaging necessary. So it can be within the brain itself, within the brain stem, within the motor neurons, upper or lower motor neurons. And there are certain things or certain symptoms which help us know where the problem is. So if the patient has a problem within the brain itself, it can be a problem with cognitive function and memory. If it's within the brain stem, we can notice a problem with respiration or consciousness. If it's a problem within the motor neurons, then we would see that there is a problem with the motor function. If it's an upper motor neuron, we would see increased or exaggerated reflexes, like a positive Babinski sign. Whereas if it's in lower motor neurons, we would see diminished or absent reflexes. In upper motor neuron lesions, we see spastic paralysis, but in lower motor neuron lesion, we see flaccid paralysis and fasciculations or fibrillations of muscle groups. Regarding physical examination, the first thing we look for, it's always like, it's similar to a physical examination in a normal patient, where you would first inspect. So you would look at the appearance of a patient and evaluate their gait, their posture, their movements, their facial expressions, their mood, their affect. MMSC, this is a mini mental state examination, which we've spoken about before to evaluate the cognitive function. Then we test their cranial nerves 2 through 12, and we perform fundoscopic examination for evaluating the function of the optic nerve. The physical examination, testing motor nerve function, testing sensory function, deep tendon reflexes, meningeal irritation, straight leg raise, and testing the coordination. We'll go through each one. So the reflexes which are necessary to test for include the corneal reflex. It means that you should, we will go through them in the next slides. This slide just shows the most important reflexes which we should test for. In the corneal reflex, you just place like a cotton swab inside the cornea of the patient, and the patient should blink. It serves as a protective reflex. A pharyngeal reflex is just to ask them to open their mouth and say ah, and you look for the movement of the uvula. The biceps and the triceps reflex test for upper and motor neuron function, and the brachioradialis is the same. Abdominal as well. The patellar or the knee jerk reflex and the Achilles reflex, again, they test for the, these are involuntary reflexes that also serve as protective reflexes. And the Babinski is important because it helps us detect if there is an upper motor neuron lesion. So cranial nerves 1 through 12, we also test for function of cranial nerves. Cranial nerve 1 is responsible for smell. So it is important to remember that when we test for the function of optic nerve 1, we always test each nostril separately. It means we have to use our finger to close the nostril which we're not testing for, and we ask the patient to smell some familiar odors like soap or perfume, and then we ask them if they're able to smell it or not. And anosmia is the condition when a patient cannot smell, and it can be ipsilateral or bilateral. For cranial nerve 2, optic nerve, which is responsible for vision, we test for visual acuity. It means we ask them to read from a distance of 1 meter, and if they're able to do so or not. And we also need to note if they have contact lenses or glasses. The pupillary size, we test using light, for example, a flashlight, and we see if the pupil contracts or not. The visual fields as well are important. It means we should test for each visual field. Fundoscopic examination to evaluate for papillary edema, which can occur in intracranial hypertension. Cranial nerve 3, 4, and 6 are involved in cranial nerve 3, oculomotor, has a function, has both parasympathetic, sympathetic, as well as motor function. So we test the pupillary reflex. We test for opening of the eyelids, and we also test for the extraocular movements, mainly adduction of the eye. For cranial nerve 4, it's responsible for the downward inward movement of the eye. So you just need to ask the patient if they're able to move their eye inwards and downwards, and if not, then it suggests a cranial nerve 4 lesion. For cranial nerve 6, which provides a lateral eye movement, you ask the patient to move their eye laterally, and if they're able to do so, then it suggests an intact cranial nerve. So injuries of cranial nerves 3, 4, and 6 can happen in case of an infection like meningitis, orbital fractures, aneurysm of the carotid of the internal carotid, mastoiditis, or increased intracranial pressure. The reason is because an increased pressure can cause a herniation, which can press on the side of these cranial nerves, resulting in damage to their function. This picture just shows each part of the eye and which muscle is controlled by which nerve. Pupil abnormalities. Certain pupil abnormalities can also be present in a patient with neurological dysfunction. The most important for us is Argyll-Robertson pupil. This is actually a pupil which does not react to light, but reacts to accommodation. We can see this particularly in syphilis. Asymmetry of the pupil can suggest cranial nerve 2 compression, and a constriction of the pupils can be seen sometimes in intoxication or trauma. Cranial nerve 5, the trigeminal nerve, as we all know, it has 3 branches: sensory, maxillary, and mandibular. Each one is tested separately. So we have to test the sensory function by asking the patient if they can feel. For example, we touch their forehead, we touch their orbits, and we touch also their jaws. We ask if they're able to move their jaws or not, if they're able to masticate, and if there is any lesion, it will cause a contralateral paresthesia on the opposite side. And most lesions affect all the 3 branches. So cranial nerve 7 is facial nerve. It has motor functions, autonomic, and sensory functions. It means it affects, like an affection of cranial nerve 7 would affect both motor function of the face, the scalp, and the ears, as well as the sensory function for the anterior 2/3 of the tongue, and autonomic function, vasodilation, secretion of submaxillary, sublingual glands would be affected. And we notice peripheral or central paralysis of the cranial nerves. And what is important to remember is that a central lesion will cause a contralateral paralysis to the lower half of the face, below the eyes. And that's because the upper part, the nucleus for the upper part, has innervations from both sides of the brain. And that's why if there is peripheral lesion, it's actually worse. So yeah. For cranial nerve 8, vestibulocochlear, it's responsible for both hearing and balance. So we have to test for both things. It means we test if they're able to hear. There's two tests, Weber and Rene test. And this allows you to know if their bone conduction is better than the air conduction or vice versa. And the result of the test will help you know if it's a conductive loss or sensory neural loss. And for the balance function, there's a Romberg sign in which you ask the patient to stand with 2 feet together, close the eyes, and maintain for 20 to 30 seconds. If the patient maintains their balance, it means that cranial nerve 8, the cochlear part, sorry, the vestibular part is intact. If not, then it suggests an imbalance, which means that the nerve is damaged. Cranial nerve 9, glossopharyngeal, is responsible for controlling the movement of the muscles of the pharynx. And it also provides innervation, sensory innervation, taste for the posterior 1/3 of the tongue. So in order to test for the function of cranial nerve 9, you have to ask the patient if you have to do the gag reflex to see if there is some elevation of the uvula and if they're able to taste at the posterior third of the tongue or not. Cranial nerve 10, vagus nerve, has motor, autonomic, and sensory functions. It means it provides innervation for the palate, the pharynx, the larynx, the neck, the thorax, and the abdomen. And it has several branches to the internal organs. The most notable lesions on physical examination, which you would be able to notice, is dysphagia, dyspnea, stridor, hoarseness, and aphonia. Other lesions cannot be so much noticed. Yeah. Cranial nerve 11, which is the accessory nerve, provides motor innervation to the sternocleidomastoid and the trapezius. So you ask the patient to shrug their shoulders against resistance and rotate their head to be able to test if this nerve is functioning properly or not. Yeah. The next slide, I'm sorry. Cranial nerve 12 provides innervation to the tongue. So you ask the patient to open their mouth and move their tongue to the sides, up and down. And you look for deviations, you look for fasciculations or fibrillations. Examination of the neck. You have to ask the patient to move their neck, basically. What are the most important movements? Flexion, extension, and rotation. What is important to notice if there's any neck stiffness or impaired movement of the neck, because this is a sign of meningeal irritation, which can be in meningitis or in subarachnoidal hemorrhage. Enlarged lymph nodes or cervical ribs can suggest a malignancy. For brutes on auscultation, they're important to look for, because if you hear any brute, it can suggest an embolism or some kind of thrombus in the carotids. So it's important to listen for them with a stethoscope. And the motor function. Motor function means you should look for symmetry in the muscle size. If there is any muscle atrophy, you palpate for the muscle tone. Percussion is not so valid here. And you check the motor strength. Usually it's given a score. You check the body position. If there's any involuntary movements like tremors. So the muscle tone, it means if the patient has a resistance to stretch or not, if they're able to, if their muscle strength is normal or not, if you have to test if the muscles can be moved against gravity or not. Yeah, and if the resistance is increased or decreased, or if it varies or persists. So it is important also to distinguish between the different terms like paresis, paralysis, hemiparesis, hemiplegia, paraplegia, and quadriplegia. Paresis is just an incomplete paralysis, but paralysis is a complete loss of the function, of the motor function. Hemiparesis is on one side of the body. Hemiplegia, paraplegia, it means on the upper side of the body, and quadriplegia is all the body affected, all the four limbs, I mean. And atrophy, hypertrophy, I think you all know these terms, so I don't need to go through them. The difference between upper and lower motor neuron lesions is depend, like for example, if they have upper motor neuron lesion, that means that they would have muscle weakness in both. But the most important thing is to notice the differences. There will be an atrophy in case of a lower motor neuron lesion, and the reflexes will be increased in an upper motor neuron lesion. So we can note the Babinski reflex, for example. The tone of the muscle would be increased in an upper motor neuron lesion, but decreased in a lower motor neuron lesion. So we would see spastic paralysis in upper motor neuron lesion and flaccid paralysis in lower motor neuron lesion. Okay, so as we said, this is again just a repetition of what we have mentioned. Fasciculations and fibrillations suggest a lower motor neuron lesion. Okay, so for the gait, some abnormal gaits include a spastic gait, hemiparetic gait, Parkinsonian's gait, food drop, ataxic gait, and waddling myopathic gait. What is important is the Parkinsonian, because the other ones are not so much noticeable, but the Parkinsonian is very is easily noticed in patients with Parkinson's disease, and it can help us really diagnose the condition. For the muscle tone, as we said, we can have either spastic or rigid muscle tone or a flaccid muscle tone, depending whether it's an upper motor neuron lesion or a lower motor neuron lesion. And a clonus is a rhythmic contraction of the muscle that happens when a spastic muscle is stretched, and it suggests an upper motor neuron lesion. The grading of muscle power, we said before that we have 5 grades. And if the muscle power is normal, it means it's a grade of 5. If the muscle power is very low, then it's a grade 0. So it depends whether you can move the muscle against resistance, against gravity. If the muscle can move, but it cannot oppose resistance or gravity. And if there's some fasciculations, flickering, fibrillations, and grade 0 is nothing. Yeah. And reflexes, upper motor neuron lesion, lower motor neuron lesion. Again, it's just here, it's just important to know that upper motor neuron lesions would cause exaggerated reflexes, but in lower, the reflexes are reduced or absent. Here you can find all the muscles and their innervations. So this can help you know what kind of nerves or segments would be affected in case of every, in case of every muscle. So here is also the spinal cord segment and its motor function. Yeah. Again, this is a repetition. This is also a repetition of the grading muscular response. Sensory function. So for the sensory function, we test the efficiency if the patient is able to feel or not, and note their symptoms as well. The pattern of testing should be symmetrical, distal or proximal. We look for abnormalities and where is the source, and if it's accompanied with some motor reflex abnormality. Spinothalamic tract is responsible for sensation of pain and temperature, as well as light touch. So these are the things we test for: pain, temperature, and crude touch. If the patient is able to feel them, it means that the spinothalamic tract is intact. Pain sensation, you can use a safety pin or some other tool, and you can just with the patient's eyes closed, you ask them if they're able to feel the applied pressure or the applied pain or not. No. And for temperature, you can use 2 test tubes. One is filled with hot water and the other is filled with cold water, or some tuning fork, and this tuning fork is heated or cooled by water, and you ask them if they can feel the temperature. So this is just a picture which demonstrates what you're supposed to do. Again, to compare both sides, it's important to do the test on both sides and to compare. The vibration sense is done with a tuning fork. We don't really do it nowadays, but some people still do it. And for proprioception, you grasp the toe by the sides, you pull away from the other toes, and you see if you demonstrate up and down. You ask the patient if they're able to locate where you touch them. That means that the sensation is intact. Discrimination or stereogenesis tests the ability of the sensory cortex to correlate, analyze, and interpret sensations. It depends on the touch and the position sense. So if the stereognosis is intact, then you proceed to other methods. So stereognosis, it means you have to ask the patient to identify the object without feeling it. So for example, you ask them to close their eyes and hold like a coin, for example, and if they're able to identify it without seeing it, then the stereognosis is intact. Graphisthesia is the ability to manipulate an object, to identify numbers written in hands and use the patient's orientation. The 2-point discrimination is when you touch like 2 places simultaneously, and if they're able to distinguish that it was 2 points and not just 1 point, then it's intact. Spinal reflexes, deep tendon reflexes, again, we have to test for brachiocephalic, brachioradialis reflex, biceps reflex, triceps reflex, abdominal, knee, plantar, and Achilles reflex. Each reflex corresponds to a different spinal cord segment and would help us suggest the problem where exactly it is in the spinal cord. There are also grades, they're not so important. This is not important. Biceps reflex, so with elbow flexion, you have to use this hammer and you have to tap on the biceps tendon. The response should be elbow flexion, and if it occurs, then the biceps reflex C5, C6 segments of the spinal cord is okay. And for the triceps reflex, the response should be elbow extension. So you tap on the tendon of the triceps muscle, and if elbow extension occurs, then it's intact. In the brachioradialis, tests for spinal cord C5, C6, the response should be forearm semi-flexion or semi-pronation, but with no wrist or hand flexion. Pronator drift is not done anymore. The patellar reflex, the response should be knee extension if you tap on the patellar tendon. The Achilles reflex, again, it tests for S1, S2 segments of the spinal cord. You have to tap on the Achilles tendon, and the response should be ankle plantar flexion if this reflex is intact. A plantar reflex, so if you strike the sole of the foot gently, there should be a dorsiflexion, or we can say plantar flexion of the foot. And plantar flexion, but if dorsiflexion occurs and fanning out effect of the toes, then this suggests a Babinski sign and an upper motor neuron lesion. abdominal reflexes are also done. It means you have to strike from outward to inward, above the umbilicus and also below the umbilicus, and you see if there is some abdominal contraction going on or not. And that would help you know if the abdominal reflex is intact. Anal reflex is not done, at least by students, but it can help you see if there is a possible lesion of the coda equina. The clonus, rhythmic oscillation, flexion, extension, upper motor neuron lesion, suggests a clonus is basically rhythmic contraction of the muscle, and that suggests an upper motor neuron lesion. Now moving on to the cerebellar function. The cerebellum is responsible for coordinating our movements, the motor function, the vestibular system, and also our gait. So there's several tests to test for the cerebellar function, which includes the finger to nose test. And it means that a patient, you should ask them to move their finger from their nose to your finger, and you should test, or you should look if they overshoot or if they miss. And the heel to knee test, in which they, as you can see in the picture, they touch with their heel. They go upwards from their ankle upwards to their other knee, and you test if the movement is smooth or not. Rapid alternating movements, or known as diadokinesia, also suggests an intact cerebellar function. If not, then dysdiadokinesia, and cerebellar function is not intact. Station, stance, and Romberg's test, we spoke about it before. Examination of the gait, especially if ataxic, for example, or Parkinsonian's gait should be noticed. You ask the patient to walk across the room, to turn and walk back. Heel and toe walking is also important. If they're able to rise from sitting position, rising from a chair. Meningeal irritation signs, it means neck stiffness. Brudzinski's sign, you flex the patient's head and you see if they have pain in the neck. If they flex their hip, upon flexing the head, then Brudzinski's sign is positive. Koenig's sign, also known as a straight leg raise test, you ask the patient to, you raise the patient's leg, and if they experience pain, it suggests meningeal irritation. Involuntary movements like tremors, tics, chorea, hemibalism, or orofacial dyskinesias suggest also some underlying disorder. So you should look for them on physical examination. So to summarize, it is important to ask the patient certain questions in a neurological examination to obtain a proper history, to identify abnormal findings, distinguish between normal and abnormal findings, locate the sign, locate the lesion, whether it's central or peripheral, to compare and test the consciousness. And that's it. And now for your questions.
Guys, feel free to use the chat if you don't want to just turn on your camera or something. Okay, well, that's the end of the lesson, or the end of the lecture even. Thank you very much all for attending. If you could please just fill in the feedback form, which I've just put in the chat, so that we can get some feedback. And thank you very much, Noor, for that lecture. It was a very concise one. Have a nice evening, everyone.
Thank you.
Thank you. Bye-bye.
Bye.